Okay, welcome everybody. My name is Terry Weber. I am with UK Elder Care, and today we have some ladies from the Bluegrass Care Navigators. They're going to be talking with us about a really important subject, death, and care and end of life type issues, things that nobody really wants to talk about, but we kind of need to talk about. They're also going to be introducing a new program they have, which I won't say anything. I'm going to let them, do the surprise for you. But I think it's something that Lexington definitely needs. This whole area needs. Anyhow, so without further ado, Hazel and Kristi are from Bluegrass Care Navigators. They're both provider liaisons. And take it away, guys.
Well, good morning, everyone. Hazel and I both, as she said, are provider liaisons in the central Kentucky area for Bluegrass Care Navigators. And if you're not familiar with that name, you may remember us as Hospice of the Bluegrass. See, it's been so long, I hardly even remember. But yeah, Hospice of the Bluegrass was formerly our name, but because we provide so many different services outside and leading to hospice care, then we changed our name about 3 years ago. I can't believe it's been that long, but been a while. So we want to refresh your memory first and foremost as to what Bluegrass Care Navigators does provide under that big heading. So I think we'll dive right into that. And Hazel and I would like for this to be very informal. If you have a question, throw it into the chat box. We'll try to address them as we go along, or definitely at the end. So feel free to share whatever your thoughts or comments are. And we'll probably tag team with each other just to give you the best information and pop in anytime. So Bluegrass Care Navigators, as you look at this little slide, it kind of gives you the overall view of what we do. And I had a gal tell me not long ago, she was introducing a new person at their facility to me. And she said, oh, Bluegrass Care Navigators, they do everything. She said, and if it's something that they don't, they'll probably add another tab, just put it out there. But what that really means to say is that we are a safety net for that continuum of care. There are so many things that we provide that help keep people from, falling through the cracks. And that's exactly what we want to do, is to be there to provide resources to help navigate people through the crazy healthcare continuum of care. So that's a little bit about why we changed our name and why we continue to add services, because we know that they're very necessary. So I'm just going to give you a very short synopsis of each of the services that we do provide and how you can access them and how they're paid for. So Bluegrass Extra Care, you're probably familiar with different types of personal care and private duty, where you might have someone come in the home and provide anything from light housekeeping to companionship up to skilled nursing. So that is one service that is a private pay. It's based on an hourly rate, and it would depend, that hourly rate would depend on, the skill level and the type of service that you may need. So Bluegrass Extra Care is provided in about 8 counties in central Kentucky and 2 counties in eastern Kentucky. So not the full range of counties that we provide with hospice care, but if there's a question, just call our 24-hour referral line and we can point you in the right direction. If we don't cover that county, then we can give you resources who do. So Bluegrass Home Primary Care would be our next service. And that is a home primary care physician who actually does the old-fashioned house call. And that is for patients who maybe they are home limited, home bound, but even if it's a taxing effort for them to get out and go to their primary care physician, then they can access home primary care. And you will have an actual MD who also is certified in palliative and hospice care, who would be your primary care physician. This service is only available in Fayette and Jessamine County right now. It is a care service that we will provide and roll out into other counties, but we want to be deliberate and intentional about it. So we are taking our time there. We get rave reviews on that. It's billed much like, or exactly like your home primary care that you would go to the office and see. So, you know, it would just be billed to your insurance, Medicare, Medicaid, whatever it is that provides your care. The Bluegrass Adult Day Healthcare is located in Frankfort. It's for adults or people who have intellectual incompetency that's maybe compromised by age or illness. And right now we are not providing our adult day due to COVID. It's located in Frankfort for a very specific reason that a lot of people who are caring for elderly parents or have someone that may need adult day, a lot of them work in government and travel to Frankfort. So it was just a good idea to have that in Frankfort where they could be close to their loved one, not separated in a different county. But like I said, that will, you know, that'll pick back up after COVID restrictions are released a little bit, and pray that soon. Bluegrass Transitional Care. This is a program that is not a consumer-based program that you can access as a consumer. It is actually, it is requested by either the hospital or the insurance provider to keep people safe and on their care plan as they're being dismissed from the hospital. It's a transition care program that would keep them, you know, on their medications, on their care plan. A lot of people who maybe are discharged to Eastern Kentucky don't have really quick access to healthcare. So what happens is that they'll end up back in the hospital in that 30, 60, 90 day, and the hospitals don't want that, neither do the insurance providers, because it's very costly and expensive. So they request for transition care to follow that patient for up to about 90 days to keep them on their care plan. So it actually saves money. Bluegrass Palliative Care, and we've got a little slide at the end of our services here to kind of give you an idea of what the difference is between palliative and hospice care, because a lot of people, rightly so, they intermix those words or even think of them as being the same type of care. And we want to be able to share with you what the difference is, so that if you need to access one of those cares, you know what you're doing and what you're getting into, but you can always call our 24-hour number. We can help navigate through it. So palliative care is a consult service that is specialized. It's focused on the relief of symptoms related to a serious illness, okay? So we're not talking end of life here necessarily. We're talking a specialized service. So it is billed as a specialist. So say you went to a cardiologist or to someone about diabetes, whatever that may be, you would be billed, you know, according to that specialty, and there may be a copay or whatever, but palliative care is a specialized service that helps you get relief from symptoms that are related to a serious illness. So think about maybe you have a loved one with COPD and they're having anxiety because they get shortness of breath and because they're maybe afraid to stay home alone in case an episode would happen. And all of those things you don't want to be popping in and out of the hospital for. There's really no need to. What they need are resources and education to help keep them at home and help keep them, you know, feeling confident about their own care. So it's not necessarily end of life with palliative care. It is improving the quality of life as you're going through some serious, you know, symptoms. Does that make sense for everyone? Okay, if not, we'll take some questions and we'll, you know, get some details on that in a minute. Hospice care. Now, this is our core service. We have provided hospice care in Fayette and Jessamine for over 40 years. So we are the experts at end-of-life care. And Bluegrass Hospice Care is provided under either Medicare, Medicaid, private insurance, the veteran benefits, If all else fails, no one is turned away for lack of payment, okay? Anyone can access hospice care because we have generous donors and providers who support the program, and we don't have to turn people away. So what hospice care provides is an ongoing interdisciplinary team that will give you a 24/7 access to care. So doesn't mean that they're in your home caring for your loved one. It means that they come to your home, you have access to the phone number, the 24/7 number, if you need a physician, if you need a nurse visit in the middle of the night because there's a crisis and you don't want to end up going to the hospital, you can get a nurse visit. I mean, you have access to someone 24/7 to help you get through whatever it may be you're doing. So you have a social worker, you have an aide, you have a physician, a nurse, a chaplain, all of the people who, and even volunteers, who can help provide that care wherever home is. So whether that be in a nursing home, whether it's in the hospital, in the inpatient unit, whether it is in your daughter's home, wherever home is, that's where we care for people with hospice care. Bluegrass Grief Care is one of the ones that a lot of people don't think about, or maybe don't even realize that we have. It is not a component of the hospice care program under the Medicaid and Medicare model, but we think that it's important enough that we provide it, and it's funded by our donors. So it is totally funded by donations and support from the community. So it's a unique counseling service that offers either one-on-one counseling, support groups, kids camps, all of these things that people may be struggling with in the community related to grief and bereavement. We can help with that. And it is not only for our hospice care or palliative care patients or anyone in our service lines, it is open to the community and it's a free service. So please keep that in mind for people that you may know who are struggling with grief, who are grieving and have bereavement issues, because we can certainly be of help there. So even anticipatory grief, as we talk about, if we know that someone is at end of life and we don't know how to handle that, what to expect, what to anticipate, we can be of help there to guide along that path. And the one thing that our grief care does do is with any of our hospice patients, once they pass, we follow the caregiver for 13 months after the death of their loved one, because we know there are a whole lot of firsts that happen in that upcoming year that may cause some grief, and not everybody grieves the same way or at the same time. So we want to be a safety net there and be able to support them through that first year. So that's a little overview of all the services we provide. I bet some of you didn't even realize all of that. So the difference between palliative and hospice. Palliative care, as we talked about, does not require a terminal diagnosis, okay? So it is actually just specialized management of chronic symptoms related to a serious illness. So those symptoms like we talked about, maybe anxiety, shortness of breath, some wound care, pain, nausea, those kind of things that would keep people running to their doctor or to the hospital. You would not have to do that. You would have a palliative care either at the clinic, which resides in Baptist Healthcare, or home palliative care. If it's a taxing effort for you to get to the clinic, then you can have home palliative care as well. So you can have palliative care alongside other treatments. Say you're accessing chemo or radiation or dialysis, and you're having issues related to that treatment, pain or anxiety. We can follow along with that and kind of be a nucleus with your other physicians and coordinate that care and look at your medications and be sure that everybody's on board together. So palliative care, like we talked about, is a specialized physician service. It's covered by Medicare, Medicaid, private insurance. Okay, so there may be a copay if your insurance has a copay for a specialty consult, then you would have a copay with this as well. Now, the thing about palliative care, because it is a specialist, much like your cardiologist, you don't go there every week or every month. You go there like maybe quarterly, check in, whatever. Appointments are made the same way here with palliative care, every 4 to 8 weeks, similar to other specialty practices. So think of them as, you know, a coordinated care, a specialized care that's helping manage symptoms that may be going on because of whatever's going on with your with a serious illness. So it's not necessarily end of life. However, palliative care can help transition to hospice care should whatever illness that you have show a decline, or you have an episode, or something goes on that now we are looking at possible end of life. Okay, so we can help transition. So hospice care would be, we would come on board when a physician is given a diagnosis that, given the natural progression of that disease, you would not be expected to live past 6 months. Doesn't mean you won't live longer, doesn't mean you might go a long time and be discharged from hospice care, because we provide such support that a lot of times people get a little bit better and are not showing continual decline, even though they may still have an end-of-life diagnosis. Sometimes they do show a little bit of a you know, a rise in their symptoms and everything, so they can go a little longer. But that's kind of the parameter. Given the natural progression, you wouldn't expect to live past 6 months. So we offer that full interdisciplinary team who can be, you know, available to you, who make, you know, very frequent visits, who can do aid care like bathing and those kind of things, set that up, you know, on a weekly basis or several times. They can provide the palliative component of managing those symptoms so that you're not running to the ER or to the doctor all the time. So it's paid, as we said, by Medicare, Medicaid, or private insurance, or the veterans benefit, or it's funded by donations. And we see patients wherever home is. That includes even the homeless population. So wherever they are, we follow them, we give the care. So if you have any questions about the difference between palliative and hospice care, let us know, because we certainly want to help dispel any myths, any fears, you know, and provide the right care at the right time.
Excuse me, I have a question.
Sure.
My mother-in-law was in the hospital, and there was a lot of confusion about putting her in palliative care versus in hospice care eventually. But one of the things that concerned me, and sorry if I've confused this, but
It's okay.
they said that they would, when if she went into palliative care, they would treat her for that main condition, but not treat her for other things. Does that make any sense to you? Like, she would not be getting all the medicines that she had previously been taking. They would be focusing on like heart failure or something along those lines.
Well, it is a little confusing, and Hazel, jump in if you have any insight there, but typically they would be managing the symptoms related to whatever the most serious illness is. So if it happened to be, you know, heart failure, then they would look at that as probably being the most serious illness, and what kind of symptoms are happening here? How can we simplify this whole care plan, you know, to really focus on what she wants, you know, what the patient desires, you know, what is their goals of care, and how do we proceed, you know, based on those wishes. So it's it's kind of a whole type, how do you put it? You know, like addressing the whole person, as opposed to focusing on just one specific thing. So does that help at all?
Well, I guess I still find it confusing. But I'll let you continue on. Maybe
Well,
I'll.
and as you'll find, I mean, as Hazel talks about different things, what blocks people from having the communication and whatnot is that a lot of physicians, even though they know someone may be within that 6-month diagnosis, have a hard time having that conversation for a variety of reasons, for whatever it may be. And so the easiest thing to do would be to refer to palliative care and get them on board, kind of, you know, seeing what's going on with that whole person and all of the things that are happening in order to transition to hospice care. I'm not saying that's always the way, but there are times that physicians don't want to be the one to have that conversation. So they either wait for the specialist or they refer to palliative care and let palliative care work through it. So it is, you know, it does kind of overlap a little bit, and there are a variety of reasons why they may refer to one and not the other. So
I just wanted to ask, when you're having that conversation, were they saying that about the palliative side or the hospice side of care?
The palliative side.
Okay.
and was that in Fayette County?
No, it was in Franklin County.
Okay. Yeah, that's got me in a quandary there, because yeah, typically, you know, you would be addressing the whole person and the, you know, all of the symptoms under palliative care,
Well, and
like
certainly
a
the goal of,
specialty.
the goal of palliative care is not to necessarily take away medications unless there's a reason to do that, you know, relates to the symptom management. But that would be, I've never heard that be a part of the palliative plan of care. They would
Yeah.
look at medications just to make sure there aren't some things that are, you know, causing some conflict or contributing to those symptoms. But
Yeah, she was. Oh, I'm sorry. She was
No, I'm done.
on a kidney medicine, and they were saying, well, we're not going to continue providing that for her because we're treating the heart.
Okay. That honestly, we could have a sidebar afterward if you'd like, but that honestly sounds like hospice care, because they will cover medications and supplies and durable medical equipment that relates to the primary disease.
Okay.
Okay.
Well, I'll let you continue. I don't
Yeah,
want to
but that's
keep
a
on.
good point. It's a good point, and you know, it raised some questions. So thank you for bringing it up. But we can talk later.
Kristi, we had a
Yep.
question in the chat box,
Uh-huh.
whether any of our services provide respite care. And that would be a level of care under the hospice benefit. So it happens inside of hospice, but it doesn't, we don't have a service that provides respite care necessarily.
Right.
Other than the private duty, which is private pay. But that is a level of service or level of care under the hospice benefit.
Right. For if a hospice patient maybe is at home and they're having some symptoms that can't be controlled in that environment, we sometimes will take them to the inpatient unit and do respite there. You know, there's a lot of reasons for that, but there are some nursing homes in town who provide respite care. So, you know, long as they're COVID negative and, you know, need a place to be short term, there are some nursing homes who will do that. So keep that in mind. So one thing I just want to touch on very briefly is our Alzheimer's support program. This is something new that we received a grant for. We worked with a lot of different entities in Fayette County to get this grant. And it's a 3-year program or a 3-year initiative to provide service and support to caregivers of people with Alzheimer's or related dementias. Or people who live alone with Alzheimer's or related dementias, or even intellectual and developmental disabilities. So it's a 6-month intervention program. It is free because it's provided by the grant to support people who are working with folks, living with and the caregiver of, or who are living alone with either Alzheimer's, dementia or related dementias, or intellectual and developmental disability. So there's 2 models depending on what type of support we're offering. The referral process is very easy. You don't have to have an actual diagnosis of Alzheimer's or related dementia. You can call in and there's a little screening that we do. And, if you suspect that someone is having, cognitive impairment or dementia of some type, we'll do an assessment and we can get you into the program. So it is provided in the same counties that our hospice care is provided, which is 32 counties in Kentucky. And like we said, they just need to have a diagnosis of a dementia. If no diagnosis, then the symptoms. So either way, we can do an assessment. And the services that are provided, they receive a monthly home visit from a nurse coach through our transitional care. A nurse or a social worker would do the assessment. They provide education, support, referrals to needed resources throughout that 6-month intervention. There's additional visits as needed. If you need an in-person visit, there are televisits if needed. There's a 24/7 phone line that you can call if you're having any kind of issues and get some help and some support through there. And then you're given a resource binder that has just a multitude of things in it that can help connect you to the people that you may need at the time, whatever point you're in this disease. So it helps relieve a lot of the burden. It helps people be tethered to something that, they're not just on their own. We can help physician offices, decrease their phone calls and just quit sending people here, there, and everywhere, because we can be one phone call away to help connect them with the resources or refer them if need be. So this is a new program. There's a number in here at the end that you can call. Any referral that you have for any of our services, including this caregiver support program, you can call our main number. So that's a little bit about what we provide, and that's a lot. You could think of us as during that continuum of care, we do everything except home health. So PT, OT, speech therapy, we do not do, but everything else around that, absolutely. We're happy to help. So I'm going to turn it over to Hazel, because as we talk about these types of illnesses and types of care and the continuum of care, before you land in one of those spots, we always advise, and we do a lot of education on advanced directives and difficult discussions, because you want to have those in place before you get down the line in that continuum of care. And Hazel's going to give you the background on that. So thank you.
Okay, you'll have to advance the slides, Kristi. So we're going to talk about why is it so hard and difficult to have this conversation that we all know we have on our mind and need to have with our loved ones. And the elephant in the room, it's an important and obvious topic which everyone present is aware of, but which isn't discussed. As such, discussion is considered to be uncomfortable. And what I love about this visual is not only have they wallpapered the walls, but they wallpapered the elephant to try and make it blend in. So they're really trying to avoid the conversation here. So why are they necessary? Well, they allow for the patient and family to plan for the future. We don't do well under crisis. We have more time to think things through and make sure that we've got things discussed and everyone knows kind of what our wishes are. We can take care of some unfinished business, whether that be financial or family issues. Certainly an important thing not to leave that for our loved ones. Time to explore and validate the diagnosis. If we have a discussion, we're not ignoring that like that elephant in the room. maybe we're able to process it by being more open and engaged in some conversation. Difficult discussion, if we can get past that, it might provide a greater sense of control over what's going on. So talking it through, being able to be honest and open would be very beneficial. And it generally helps with the death story and therefore the grieving process. And there is evidence that proves that people who've been able to have advanced directives and healthy conversations on the before the person passes will have a better experience and a gentler process in the grief and bereavement part of healing. So what are the types of difficult discussions? Well, we've got that urgent one, that crisis mode, when we're faced with a sudden crisis and a need for rapid decisions, sort of a 911 emergency department or code with no advance directive. Now we're making decisions under pressure and in a moment's time. There are spontaneous discussions, which are somewhat urgent and unplanned. We might have to address an immediate issue. They come up and we can handle it. And then there's the planned and structured advanced directive conversation that we need to have. We can have significant change in status based on the patient autonomy and personal meaning, value, and quality of life. So if we can be more focused and diligent and strategic about having that conversation, we can certainly have a peace of mind and comfort knowing that we've got things in place and things talked about. Okay. So what are some of the barriers? Well, Kristi mentioned this a little bit earlier. Medical providers aren't really trained to have this conversation. And now, you know, I'm sure everyone's realized it in the last 4 or 5 years, your time in front of, you know, face time in front of your physician has been reduced down to about 8 minutes if you're lucky. So they certainly not only don't have the training to have the conversation, they don't have the time. They're too busy to discuss and get involved in these conversations. So that kind of puts the burden back on us to be able to have the conversation with our loved ones. There's also some fiscal incentives. Actually, money is going to drive some oncology, some surgery, some cardiac intervention, or those frequent flyers that come back to the hospital. So believe it or not, there's this sense that maybe there's one more thing, one more test, one more procedure that we, you know, are being offered or it's being suggested. And those things can certainly be a barrier to having a hard discussion. General misconceptions about end-of-life care options. You know, unless you've maybe had an experience with hospice directly, you don't know how it can help, what it can do, what it would be like, or what your life, that death of your loved one might be like if you didn't have hospice care to help guide you through that. I know Kristi and I spend a lot of our time correcting misinformation before we can actually give the right information, because there are misconceptions about end of life and how it looks, how it goes, and how we can help. So we have to kind of get over those misconceptions to get to the actual, the real details of what's available and how it can help. Providers that maybe don't care, they're just, you know, they're burdened, they're overwhelmed, they're overloaded, they're overpatient. Their caseload their patient load is very high. And so they might be experiencing some burnout or some compassion fatigue. They may just not be able to go, you know, with that conversation from their emotional standpoint, so to speak. Some other barriers, our death denying culture, our medical culture. You know, we're really sort of medically oriented. I know that we tend to think, especially as people are able to live longer, that we're all going to be able to live longer, that there should be one more medical approach. There should be, you know, look at the commercials on TV offering all kinds of medications and treatments and different things. So there is sort of a sense that we're more of a medical culture of healing and curing, but no one is going to escape the end of life. There's a lack of information or confusion about documents such as living wills, DNRs. People aren't familiar with these. I know that there's a lot of elderly people. I've done presentations over at the senior center, and many people will say, you know, if you ask a room of 20, how many have an advance directive, you might get 3 hands up. And other people will say, well, I'll leave that for my daughter, or I'll leave that for my son. You know, we need to be sure that we put these things in place so that when things change, because we know they're likely going to, then there's not this sense of not knowing what to do next or what anyone would have wanted. Maybe there's not enough understanding about medical terminology. You know, when our doctors talk to us or a specialist, they may be using terms and talking about treatments, and we don't want to question what it is, or we don't even understand what it is, but we trust the physician and we kind of go down that road. There could be a fear of receiving no care if a living will is signed. And that's not a good reason to not do a living will, because certainly if you go through that process, you'll understand how it works and how it can be a benefit at that time. State-specific directives and laws make portability of directives difficult. They don't go across state lines in all states. So that can be a very challenging reason to try, to complete an advance directive. So what do patients with serious illness want? Well, you could ask yourself this question: what would I want if I did have a serious illness? And you'd probably come up with these kind of things: pain and symptom control. You want to feel you're in control, that you have some say in what's going on and what's going to happen. They want confidence that their needs and wishes will be followed. Especially if they have something very specific about what they want at that time. They also want to relieve burdens on their family. My mom used to tell me she was didn't want to be a burden to me all the time. And the reality was she wasn't, but her perception was that she was. So you could have a conversation about these difficult discussions, and you could relieve some of the burdens of family. Strengthen relationship with loved ones. Once we get past the elephant in the room, we're able to really find out about some of the sort of sacred and special things that our loved ones and our mothers, fathers, sisters, brothers want to have and share. So do you have a living will? And what is an advance directive? The term advance directive describes two types of legal documents that enhance and plan for and communicate your end-of-life wishes in the event that you are unable to communicate. And I think that's the key takeaway here today. When we said that one of the barriers was you thought you would receive no care if you had a living will, the truth is that the living will only goes into effect, and it's based on what you've instructed there. It only goes into effect if you are no longer able to make your needs known. So not everyone would have a living will that would be activated because they may be cognizant, for well into their illness. So a living will and a medical power of attorney, those are advance directives. The living will allows a person to state what care they would or would not want facing a medical crisis. So you can make some decisions. You can get good information, ask those questions, find out what CPR really does, how it works, what are the outcomes, different things that you can educate yourself on, and then make those decisions known, and you've got it written down, and it's not going to be one of those urgent situations in a crisis. The medical power of attorney, sometimes called a healthcare proxy, appoints a person to speak on a person's behalf if that person is unable to speak for him or herself. So that's where we get into a surrogate and a power of attorney. Some states in the U.S. combine living will and medical power of attorney advance directive document, while some states require separate ones. So who can complete an advance directive? Well, everyone that's over the age of 18 should consider completing an advance directive. Anyone that has a sound mind to understand the implications. This is where we talk about capacity and what that means. It means your ability to understand information and your ability to weigh the benefits and burdens, to be able to make a good decision and a choice. And when you talk about capacity, one way to understand that would be if someone was told some information, can they return that? Can they speak that back to you in an understanding way, so that you know that they're actually understanding what is being said or what information they're being given? So anyone with a sound mind can complete an advance directive. The discussion should be based at the level in which the patient can understand the content. And that gets back to that capacity issue. Got to make sure that people understand what it, fully understand what it is they're actually asking for and signing to do in that advance directive. So when does it go into effect? It goes into effect when you can no longer make decisions, when you can no longer give an informed consent, and when you can no longer communicate your healthcare decisions to others. And this is why it's so important to have these things kind of laid out and formalized before we get to a point where now we're not able to be involved in making those decisions or giving an informed consent. It's not in effect if you're able to make decisions and give consent. So it only becomes active, it's only activated when you can no longer make decisions or speak for yourself. Is it required? No. But without it, think of the roadmap you don't have laid out for your family. Others may have to make decisions for you. That could be a guardian, a spouse, majority of adult children, a parent, nearest living relative. So now you're kind of putting it on them to make decisions, and they may not have ever had a chance to know what your wishes would have been had this been the situation that they're now in. So some documents to consider: the Kentucky Most form. That is, we're going to look at that in a minute. The Kentucky Living Will, the Kentucky EMS DNR, and the 5 wishes. So where do you start? Well, you're going to identify the closest family and friend that would be give good advice. One second, I wanted to write down a note here. So you're going to name a healthcare surrogate, someone you know well, who will make those decisions on your behalf. And most people kind of think of their immediate, like, spouse or sister or brother. It doesn't have to be a family member. It just has to be someone that you know will honor your wishes and go, kind of advocate on your behalf should that time come. One thing that's important too to keep in mind: once you've decided or you've considered someone as a surrogate or power of attorney, you need to have that conversation with them, make sure that they are agreeable to do that. You also want to be sure to let them know when that's actually happened that they are now designated as that surrogate. You can talk to your doctor about any questions and concerns. Again, this gets back to maybe a little bit of gathering some information to understand some of the things that would be put in place if you didn't designate them not to be, such as CPR. And then understand that this is the beginning conversation from a person's perspective, and choices may change over time. And certainly that would be the case, where you're at when you're 35 or 40 or 50, now you're 60, or maybe you're 70. And you can imagine that what you would have wanted when you were 35 is not necessarily going to be the aggressive treatment that you might wish to bypass when you're in your 70s or 80s. So sometimes, things can change. This is the Kentucky Living Will. It's online. You can download it. They've got instructions how to complete it. So that's the living will that we want to be sure we get in place. This is the Most form, which is the medical orders for scope of treatment. This is a sort of more expanded advanced directive. It's for people that usually are having, maybe have a chronic illness or disease that is very challenging. And so not everyone would be completing this unless you really have sort of a chronic condition. But this gives you an opportunity to talk about things and make choices a little expanded from a living will. So it goes into everything from antibiotics, use of antibiotics, do you want no antibiotics, fluids and nutrition, of course the CPR, and all kinds of different interventions. So you can be a little bit more selective and intentional with certain things that you may or may not want done. And so this is new to Kentucky in 2016. One of our chief hospice physicians actually helped get this in place through the legislation in Kentucky. So that's called the Most form. This is the EMS DNR. This is the form that needs to be completed and ready to go should you need to be transferred by an ambulance service. If you didn't want to be resuscitated, they've got to be able to see this form quickly, or if it's not in place and they don't have it, they're going to have to do whatever they are called to do. So it's an order that applies to resuscitation attempts by health providers in a pre-hospital setting. And usually it's considered that transportation, or when someone's called to your home, if you call 911 and they come to your home. So you want to be sure you can complete that. It's a blue form, and you can have several copies so that they're all, they're with you, where keep one in your glove box, take one, put one in the kitchen cabinet in your kitchen, keep it readily available, not in a file drawer, and make sure people know that you've completed it. And then there's the 5 wishes, which is kind of a unique advance directive. It's actually a legal document in 42 of the states, including Kentucky. It's used in all 50 by attaching it to a completed document to the state forms that are required. And what's unique about the 5 wishes, it's an 11-page document, and it's a little bit more of a workbook style. It's comprehensive. It's something that you could complete over time. It doesn't necessarily have to be done in one setting or sitting. It identifies what you need to consider when you're making your choices. And it's everything from the different wishes are, the person I want to make my healthcare decisions for me when I can't is wish number 1. The kind of medical treatment I do or don't want. How comfortable I want to be, so that could get very specific. How I want people to treat me. This is, respect, dignity, what else you might like done should you be at the end of your life. And what I want my loved ones to know, which is a little bit of a diary or a journal. It's a place to put some special notes. So this is a great, I think it's very user-friendly. We actually have copies here in our office, and you can also get them online. It's a really wonderful document that lets you be a little more expressive and intentional about what your wishes are. Not so much of a checkbox. It's a little bit more, would you want music playing? Do you want to be at home? Do you want your loved ones around you with your pets? And what is it you want? And so that's the 5 wishes. So the single biggest problem in communication is this illusion that it has taken place. And that really sort of encapsulates this difficult discussion, the little bit of a hesitancy towards palliative and hospice care, and end of life. So,
and I think on that, Hazel,
yeah.
we love this quote, and we use it all the time, because you can fill out all the paperwork you want. You can have your living will and all your documents and the 5 wishes all laid out. But if you don't tell somebody about it, if you don't have your healthcare, your POA or your healthcare proxy in the loop on it, or your family, or they don't know where to find it in your house, then what good is it? You've gone to all that work and nobody knows, and nobody knows they're the one who needs to implement it and carry out your wishes. So
Yeah.
That's why we love this quote, because you can't talk about it enough.
And it shouldn't be kept in a safety deposit box. Any of your documentation, you've got to be able to have it readily available. Your power of attorney should have a copy. You need to let people know. That's really important, so that they aren't scrambling or bypassing and not realizing it's even in place. So that's really true.
Hazel?
Yes.
There's a question in the chat box, and I just want to make sure that it was addressed and answered, or that
Okay.
sure that it says, when should a most form be completed? You talked about the most form, but I just want to make sure that she got the answer to
Right.
that. Should it be
The most form is really people who have chronic disease, a CHF, COPD, maybe even a cancer that that's progressing. So it's kind of a unique, special document that really allows you to have this conversation with your physician and know more specifically what you want to happen and what you don't. They need to be reviewed every year. So there's a little bit of a time frame on those, whereas other advanced directives don't expire. You might change an advanced directive, which would mean you complete a new one and dispose of your old one. But the most form needs to be completed annually. Needs to be signed by a physician. It's just, they use them, I think they're using them almost exclusively now in the hospital. When people come into the hospital, the most form should travel with you if you go from the hospital to a nursing home. But it's really for people that are facing a chronic debilitating disease. So not necessarily, everybody over the age of 70, and it's not anything like that.
Okay.
I
Um,
think to piggyback on that, Hazel, is that your living will outlines, just the briefest things. The most form kind of takes that a little bit further, okay? And so you definitely would want those to match. The most form is an order for scope of treatment. How much do I want done? What do I not want done? It's signed by a physician. The living will is a legal binding document. So if they don't match, the living will is going to trump the other one, okay? So you do want them to match. You want all of your directives to be, matching and to convey what your real wishes are.
okay. I hope that answered the question for her. There was a comment someone typed in, and that's when you were talking about assigning or asking someone to be your surrogate. A friend of mine asked me to be her healthcare surrogate because she thinks her husband won't be able to make the decisions. I think that's very interesting. Yeah.
That's the way that should go. That's how that should be. That's a very good choice, actually. And I'm assuming the neighbor agreed, but that's where people get kind of emotional, like maybe get caught up in some emotional part of it. But what you want is who's going to actually honor what I've requested here. When my mom was, she had CHF, and my brother, I'm one of 7 children. I'm the only, he's the only boy. He lived in New York. I lived in Chicago with my mom, close to my mom. And he was the healthcare power of attorney for years. And finally, when things were changing, I said, Mom, he has no idea the day-to-day where you're at. So she changed me to the healthcare power of attorney, and he kept the financial side, which was a really good solution. So you got to kind of think about who is that right person for where I'm at, and if things were to change, who would be able to make those decisions for me or honor my decisions. A spouse might not be able to. They might be too emotionally tied to really be able to do what you even ask. Or you might end up in a situation where you and your spouse are together and you have some sort of accident that, neither one of you can help the other. So you have to think through about who that surrogate, the right person is to be that surrogate. And of course it can change. You just have to do new documents, but you have to give it a lot of thought. And I know someone asked about the links to these documents. So we'll be sure that when we send everything out, we have the links to the most form and everything. I think we've got, Kristi and I can pull those together and get those to Terry.
Yeah. There's another question. If the legal papers already covers the DNR wishes, can this be shown to the EMS? It's been filed with Fayette Clerk of Courts with a book and page.
Yeah, I think so. I really, do you know, Kristi?
They are trained to look for the EMS DNR, which is on the blue paper, which is specific to when 911 is called. So I've done some training with our local ambulance company, and they said, that's the first thing we look for. And typically you would want to have that on the side of your refrigerator. If you are, caring for someone, or you are that someone who is at end of life, and I don't want them doing all of this if I have to go to the hospital, then you would want to put that above your bed or in the door frame to your bedroom, or, right beside the front door, somewhere where they're going to see that, because
they're not going to look for it. Yeah.
No, they're not going to go digging around for it. And, you hate to tell this story, but, it's kind of necessary. If you have a 90-year-old grandmother who weighs 96 pounds and is dying of cancer and does not have an EMS DNR, okay? She can't breathe, something happens, you call 911, they show up, they are required by law to do everything possible to keep her resuscitated until she gets to the hospital. What that means is CPR, maybe a trach, maybe a this, maybe a that. You know, and is that what she really wants? They will perform everything on that woman that they would do on an 18-year-old who was in a motorcycle accident. But look at the difference in the patient, in that person. You know, is that really going to have a good outcome? So, you know, the EMS DNR is pretty important, and you wouldn't have that unless you already have a DNR in place. So if you absolutely know you do not want to be resuscitated, or you don't want the attempt of resuscitation, then make sure you have the EMS DNR to back it up as well.
Yeah, because I'm thinking they're not going to take the time to read a living will and find it in there either. So I
They
think
don't. They've
yeah.
told me that. Yeah. And it's sad as it may be, you know, they're in a hurry. So, yeah.
Yeah, I suggested, you know I have found that form through just Googling Kentucky EMS DNR form. I mean, that's how I have found it. So who wrote that? If you can't find it by doing that, just let me know and I'll try to find it for you. But yeah, everything you said is exactly what I've always been told about EMS and DNR. So,
well, you need to have originals. You can have multiple copies, you know, multiple pieces of it, but they all have to be originals. So you can't take photocopies of it. You could, but you can have multiple ones of them signed so that you know, got them wherever you need them.
yeah. Okay, yeah. All right, let's see do we have any others? I'm sorry. Would you please share these online on forms on link online? Yes, we can share the forms online. I don't know what I'm saying here. Would Bluegrass Care Navigators be able to provide service to help someone make decisions about the options of and completing a most?
I know our social workers do it all the time.
With our patients.
With our
Yeah.
patients.
You know, our social workers are available to help navigate through that when they're a patient in our service line. Otherwise, the most form you would want to fill out with your physician, because since it is a medical order for scope of treatment, that's where you start. And they typically will then review that with you on your annual visit.
Okay, that's good to know. And yeah, so you'll get me the most form and I can try to find the EMS DNR form and we'll get those posted on our website.
Yeah.
At www.uky.edu/HR/eldercare. But
And Terry,
just let me know.
you got the 2 pieces that I sent yesterday?
Yeah, I sent those out to the people that pre-registered.
Okay, good, because in the one that outlines kind of the advanced directives and kind of walks people through that, it's about a 3 or 4 page thing. There's information in there on how to access these forms,
Okay, great.
but it's much easier if we send you the link.
Yeah, yeah.
And I wanted to make note in the chat box, somebody said that they did use the 5 wishes and that it was a really good way to have that discussion. And it really is. It's a way to ease into things. And there are now different games out there, like the Hello game. And you may have seen some on Facebook and whatever, and they're little cards that you just draw a card and you share your answer with your family. And it's a way to try to break the ice and get those conversations going. I mean, if you're like most families, my daughter looks at me and she's like, would you just quit talking about it? You know, because whenever we're together, I'll say something. And she's like, do we really have to have this discussion? I'm like, yeah, we do. We really do.
Well, I think there's a lot of relief having done it, having completed it. You can kind of let that go now and, you know, get back to life. So
yeah, you know what you do? You pray for the best, you plan for the worst, get it done and go on living. It's like cleaning out your garage. Once you get it done, there's such a liberation to it, you know? So yeah, it's a process. I won't kid you, but yeah.
I think the other thing about 5 wishes, real quick, because I know we're out of time, is that it has information to prompt you for things that you wouldn't necessarily, you don't have to come up with what you're thinking about. it guides you through. It has prompts and choices. So it's really good for that. It'll help you think things that you wouldn't necessarily have thought about.
One little tidbit before I let you go is there was a woman I was talking to once, and she was so frustrated that her family wouldn't listen to her wishes. They just didn't want to hear it. It was kind of like what you were saying, Kristi, with your daughter. So what she did was she invited everybody over for dinner, but she wouldn't serve it until they had a conversation. So she made everybody sit around the dinner table and talk about what she wanted and the form she was going to fill out and who was going to be her surrogate and directive and everything else. Then she served dinner.
Oh, that's classic.
Awesome.
That's
Isn't that a
awesome.
great story? I love that she did that.
Yeah, that's really good.
Anyhow, I know we're out of time. Thank you so much for sharing your expertise with us. I think those
Oh my goodness. Thank you for the opportunity. And,
Really
and
enjoyed it.
you know, our information is right here on this slide. So feel free to reach out to